Welcome to Direct Primary Care Benefits Podcast, your resource to understanding how DPC and the direct care model is fixing healthcare for employers and individuals alike. Learn from the most innovative and disruptive business executives, brokers, physicians, and healthcare influencers that are in the trenches, changing the way employee benefits are being administered across the country. I'm your host, Brett Shoemaker. Well, welcome back to Direct Primary Care Benefits Podcast. This is episode 8, and I am your host, Brett Shoemaker, and I am super stoked, excited, honored, privileged to have today's guest, Mr. David Contorno from North Carolina, which is just an amazing person in the employee benefit space. And so I am going to let him introduce himself because there's so many accolades, David, that I could just start on, listing out for you. But go ahead and introduce yourself and tell all of our listeners out there, employers and brokers are our primary audience. We also have individuals. So go ahead and introduce yourself to the audience and tell them a little bit about what you do.
Great. Well, the only accolades I care about is how much we save employers and employees in healthcare and how we drive them to better outcomes. It's the only accolade that I care about. But having said that, I've been doing health insurance benefits for employers since I was 17. I'm about 46 now, so we're about 29 years. And, listen, the first 20 years were super easy because I was selling the same products at the same pricing as every other broker. So my only differentiator was how much they liked me or how many other services outside of health insurance I wrapped around it. And the beautiful thing was that I was paid commission plus bonus. But the commission meant that I got a raise every year because when my clients' rates went up 10%, my compensation went up 10%. It was the best business to be in. And for any business out there, business owner listening to this, I want you to understand that as a commission-based broker, I had no inventory that was depreciating. I had no accounts receivable because I got paid by the carrier and every one of my clients paid their health insurance bill often before any other bill. I got a 10 to 15% pay raise every single year for not doing any more work. It was easy. But I had a awakening about 12, 13, 14 years ago. I was on my way to a client meeting. It was a renewal meeting with an existing client. And I realized that not a single one of my clients looks forward to that renewal meeting every year because I'm bringing in varying degrees of bad news. And I didn't want to be in a career where nobody looked forward to meeting me. But you know what got really hard for me, Brett? It wasn't the meeting with the employer. Because when I sat down with that employer and we sat down at a $40,000 conference room table wearing $2,000 worth of clothes, both of us having driven in our nice German automobile, we could afford a 10% increase in what's coming out of our paycheck or a 10% increase in our deductible or out of pocket. But you know who couldn't? The employees that I had to go meet a few weeks later and tell them what the decisions were made at that table. And I realized this one time that I'm going into a group of people that probably don't have $500 in their savings account. And I'm showing them a plan with a $3,000 deductible and a $5,000 out of pocket. And I started to see statistics. One statistic that still fuels me to this day is the number one cause of bankruptcy in the U.S. is medical bills. But the huge majority of those people had health insurance. Now, I want everyone listening to this to think about every other type of insurance you buy except health insurance. It serves a singular purpose. I don't care if it's car insurance, life insurance, homeowner insurance. It serves a singular purpose, which is to protect us from catastrophic financial loss, from events that are unlikely to occur, but severe when they do. And let's face it, we expect health insurance to do that too, right? Cover the cancer and the heart attacks. But now we've come to expect it to cover the brakes and the tires and the windshield wipers on our car, right? We want it to cover the annual physical, the strep throat, the ear infection. I got to tell you, insurance as a financial vehicle doesn't function when it's trying to protect both the infrequent severe and the less severe frequent events. It just doesn't work that way.
Well, you said a mouthful, and I just absolutely love everything you said, and the analogies that you use make perfect sense. And so what I want to do is talk about those perverse incentives and, inverse relationships as they relate to insurance, because like you said, and like I've heard you say before, and we had a conversation offline, is, health insurances are health insurance, health care, whatever you want to call it. The healthcare industry as a whole, as people see it, really isn't broken. It is working as it's designed. And what most employers, individuals, and everywhere that I've come across is what I have found, David, and I'd love to hear your take on this, is they have created so much confusion and so many different layers of incentives that are adverse to the actual patient, as you've mentioned, that it's just created a mess that is, making everybody else rich, but making the folks that it's supposed to serve poor, and primarily because all of the different layers and confusion. So what is your take on that?
Well, the system, if you look at who makes money where and when, is working exactly as those incentives command. So we talked about the broker who's typically paid commission plus undisclosed bonuses on top of that. And the bonuses are tied to new business and retention. And I used to get calls from United Healthcare all the time that said, David, if you lose one more group with us, your bonus is going to go from $250,000 to $100,000. Or at the end of the year, Blue Cross would call me up and say, David, if you write just one more group with us, your bonus is going to go from $100,000 to $250,000. I don't know how brokers can deny that influences them when they keep on making those bonuses year after year after year. They may not recognize it's influencing them. Maybe I'll give them that much credit. I don't know. I don't know that I really recognize it at the time. But let's go to the next link in the chain, your insurance carrier. Most employers think that an insurance company makes more money if they have claims cost less by denying claims, by negotiating better quote-unquote discounts with the hospitals. And that is completely not true. And it's the number one thing that employers need to wake up to. The medical loss ratio provision of the Affordable Care Act says that all fully insured health plans in the U.S. must spend a minimum of 80 or 85 cents on every dollar they collect. It's 80 cents in the small group market, 85 cents in the big group market. So 85 cents, that allows them to retain 15 cents of every dollar. Now, 15% of a bigger number results in a bigger number. So the only way for them to get more profit is for premium to go up, and the only way for premium to go up is for claims to go up. Interesting story. United Healthcare, the largest insurer in the U.S., they have two big blocks of business. One is called their commercial. That's where employers sit. That's where individuals sit. That's where ACA plans sit. And the other is Medicare. Now, in the employer market, the medical loss ratio applies. So as costs go up, profit goes up. And guess what happens in the commercial market every year? Profit and costs go up. Interestingly, though, the Medicare market works differently, and it's not subject to a loss ratio. When a Medicare beneficiary goes onto a Medicare Advantage plan with United Healthcare, like the AARP plans that are advertised all over the place, the government says to United, okay, here's $600 or $700 a month. That's meant to take care of all their care. If you spend under that, you keep the difference. If you spend over that, that's on you. So in that model, lower cost means more profit. I encourage anyone who's insured by United Healthcare to listen to their investor call every quarter. It's public. You can dial in. You're going to hear costs are up in the commercial side, so profit is up. And you're going to hear costs are down on the Medicare side, so profit is up. So what I want you to understand is it's not that United Healthcare can't control costs. It's just that for the majority of people listening to this, they're not incentivized to do so.
David,
and the last piece I want to say on that.
Go ahead. Say your last
piece on this. A lot of employers might then say to me, but I'm self-funded, so the medical loss ratio doesn't apply to me. And that's true. The medical loss ratio doesn't apply. But 99% of employers are self-funded with Blue Cross, United, Cigna, Aetna, which means the cost of care and the cost of prescriptions are running through all the exact same contracts as fully insured, which means you're getting the exact same result as you were fully insured. The only difference is you get to see a little bit better inside the plan on how badly you're being taken advantage of. That's the only difference between self-funded and fully insured.
So before I ask the question I want to ask another question is, so the reality is the solution is direct contracting on every aspect or utility inside the health plan. Would you agree with that?
Well, with the vendors, yes. You need to directly contract with all the components of your health plan, and you need to understand how they are all getting paid and make sure they're being paid in a way that aligns with your end goal. But as far as direct contracts with providers, we have thousands, tens of thousands of those, and they help, but they're not required. I mean, we don't go to a restaurant that we have a direct contract with. We don't have to go to a grocery store that we have a direct contract with, right? We don't need a contract to get health care. You just need a patient, a doctor, and a way to pay. It doesn't require a contract.
Absolutely, 100%. I agree. It can be a subscription model to a direct primary care office, right?
Yeah.
Which I know you're
Yeah.
a huge proponent of direct primary care, and I want to dive into that a little bit later, but I'm really excited and I want to stay in this vein here. So let's ask you this, because you've been in this game a long time. I have my own opinions about this, but why and where did this get mixed up? I know 1987 has a big influence on that. But when and where did this get messed up, and why has it not changed yet? Because we know it's changing. It's just a matter of time. All these direct primary care doctors, they have built it from the ground up, which I honor and respect them for, taking that risk, but it's happening. And I don't think there's a way that anybody can stop this change, but I'd love to hear your take.
Sure. Well, I would argue that it started with some of the major wars that the U.S. was in. When we were in, I believe it was World War II, we were spending a ton of money on industry to support the war effort. And the government was afraid that people would have to pay people more, thereby inflating the costs for the government and thereby making it unaffordable for them to support the war effort. So they put a national wage freeze in place. You were not allowed to give employees wage increases for this period of time while they were supporting the war. So employers were making tons of money and they were desperate to hire people. So they couldn't raise pay. So instead, that was when the first time they offered health care. And the first problem with the U.S. is that we now tie our health coverage to our job. That's problem number one. Problem number two began in the 70s, early 80s when HMOs came out. The premise of an HMO was, because before that, you could see any doctor you want to see. As a matter of fact, you went and saw the doctor, you paid out of pocket, and then you submitted it to your insurance company. And that created not only a direct relationship of payments with the provider, but it meant that a provider couldn't charge the average American $50,000 because they didn't have the money to lay out. And when I was born, my whole birth cost a few $100s in the 70s because mothers had to pay that out up front. They couldn't charge $30,000. They wouldn't get paid ever. But then HMOs came about. And the premise of an HMO was, what if we create a small network of doctors? And what if we approach those doctors by saying, hey, we're going to build a health plan where they can only see you and a few of your competitors. And we're going to drive patients to you. And by giving you this volume, we want you to give us a discount in your reimbursement. And so the first HMO was born. But let me tell you what happened. I promise you this. Some broker in the early 80s, when I was still too young to be doing this, walks into an employer and says, listen, I know your healthcare costs are going up, but I got this great thing called an HMO. And the guy says, but I'm not going to tell my people where to go for healthcare. That's crazy. I've never heard of that before. And he goes, I know, but listen, we're going to get discounts. It's going to save money. And by the way, we're only putting in quality doctors. So this small group of doctors have been vetted out for quality. Furthermore, your employees are no longer going to be able to go to a specialist without getting a referral from the primary care doc, because if your employee has a back problem and they go right to a back surgeon, they preordain back surgery being the most likely outcome. But if they go to a primary care doctor, they might recommend physical therapy or pain injections or chiropractic or whatever. So this is in my mind what I'm telling you now, but I imagine the employer said to that broker, that's crazy, but the savings are compelling, but there's one problem. My wife's OBGYN is not in your network, and I can't go home tonight if I tell her that she can't go to her OBGYN. So if you get my wife's OBGYN into your network, I'll move my whole company to your HMO. So that broker calls up that carrier exec and says, if you just get this one doctor in the network, we get the sale. And so that carrier exec went to their head of provider relations and says, I don't care the cost. You get that OBGYN in the network. It's one doctor. Who cares? Well, one doctor led to two, led to three. Today, networks have what? 97% of providers in the network. So how much discount are we getting by funneling patients when they're 97% of their competition is in the same network? And we've removed that gatekeeper to where members can go right to the back surgeon where they preordain back surgery being their most likely outcome. And I want to point something out. In the U.S., do you want to know the number one reason for back surgery? It is correcting a prior back surgery.
Unbelievable. Well, here's the thing. What you just laid out, I'm so grateful and appreciative that you did that, because in my mind, right, because of course, when you're in the direct primary care space, which I talk to employers every single day because that's what I do, the biggest question that you get on the front end, once they love the model and they hear how it works and how amazing concierge level care that their employees get, they ask, what if blah, blah, blah about their specialist or this other doctor? And you're right. And I say, look, So they basically say, well, it's kind of like a HMO, so it's not as good as a PPO. And I'm trying to explain to them, yes, but HMO and PPOs are both trash because the reality is you need that direct relationship with the doctor so that they can guide and direct what is the best and most affordable care for you. And that's the thing about it is everybody really should look at themselves as a customized approach. I love what you said earlier. And the biggest problem being that employers are dictating healthcare. And you're so right, because that's where it got kind of convoluted, right?
Yep. You said one thing. You said you need to have a good relationship or direct relationship with your doctor. And I agree with you. But you need to have a relationship with the doctor. And if anyone listening to this is seeing a traditional primary care doctor, here's my question to you. Have you spent more than 12 minutes with that doctor face-to-face in any 12-month period? It's unlikely that you have. I'm not talking about their office. I'm not talking about their physician's assistant or their nurse practitioner. I'm talking about the doctor. Because let me tell you, that doctor is seeing 30 or 40 patients a day just to feed their requirement for the health system they work for. That means they have 3,000 patients assigned to them over the course of a year. They're spending 6 to 7 minutes per patient. You might think you have a good relationship with your doctor, but I promise you, your doctor didn't remember anything about you until he or she was walking into the exam room looking at your chart, and the only thing that he or she knows is what was in his face at the moment. Not when they're seeing 3,000 patients a year. It's just not possible. So you need a relationship with a doctor, and you need a relationship not with a back surgeon, not with an endocrinologist, with a primary care physician. They are called primary care physicians because they are where we are meant to go primarily, both in terms of first and most frequently.
Absolutely.
But we don't do that, and we're totally stepping on all their training and all of their schooling.
And the reason... Keep going.
The biggest difference between a primary care doctor and a specialist is this. A primary care doctor is trained in school to be a diagnostician. They're meant to uncover what the root causes of your disease is. A specialist is trained to treat the symptoms. So a specialist, if you come in with high blood sugar, is going to give you metformin to lower your blood sugar. A primary care doctor that has the time, which most don't, but a primary care doctor that has the time is going to uncover why are you type 2 diabetic? What can we do to get so you don't need to take medication? And I have a lot of car analogies, but we wrote this one car dealership, and this one woman comes up to me with this whole list of drugs, like literally like a scroll. And she said, I need to know if these drugs are covered. And I said, okay, well, we'll take a look. But a question, have you ever thought of trying to get off some of these medications? And she says, oh, no, I need all these medications. And I said, listen, I'm not a doctor. Let me clarify. But most medications, not all, are similar to if I walked into your dealership and I said, hey, my car's making this thumping noise. And the faster I go, the louder it gets. Something's jarred in there and loose, and I don't know. It's not good. And she said, oh, no, I got a solution for you. Here's a pair of headphones. You won't hear the noise anymore. That's what most medications are. They're not addressing the issue.
Absolutely. Well, listen, oh my gosh, I love what you said. Now, I want to ask you a question, because this is a loaded question, and I don't know what you're going to say, but this is the Direct Primary Care Podcast. What type of primary care physician do you think, recommend, and know is the best for people?
I mean, we prefer family physicians. DOs too are really good, but we want a doctor that can holistically treat not just the person, but also the family as well. So we prefer family medicine docs that can do peds and female women's health. And therefore you're only calling in a specialist when truly an interventionalist, a true specialist is really necessary. And primary care doctors who have the time are very well trained to handle, mild anxiety, mild depression, mild diabetes, like what most people suffer from. It's the acute situation or the multiple comorbidities that should be going to specialists. And even then, it should be under your primary care doctor's supervision, because your primary care doctor should know the most about you. They
Amen.
should be that second opinion as a specialist. They should be making sure that once you're done as a specialist, you're back under the primary care doctor's care. You're not being treated by an orthopedic surgeon over and over again. I've seen so many people who said, my orthopedic surgeon is great. I've had my shoulder done 3 times with him. I'm like,
Of course he's great.
Shoulder done 3 times.
Of
right?
course he's great because you're paying him over and over again. It's so crazy. But people don't understand this because you know why? That specialist is giving them time and attention. And what they don't understand is that this whole broken healthcare system has created people to use the more expensive versions of care, the urgent care, the ER, because why? People have done it out of convenience because it's such a pain in the butt to get into a primary care office because they're churning 30 patients a day instead of like what we do at First Primary Care. We only see 600 patients per panel. So we only see probably in the office maybe 3-4 patients a day, if that, because 85% of it becomes 85% of the care ends up being done virtually, not because we want to, because by virtue of the model, when you have that relationship, you have that healthcare history and that relationship with one doctor, you don't need to come in necessarily unless you have one of those acute issues that are being diagnosed.
Mm-hmm. Yep, absolutely. And the way that we build plans for employers using DPC is we typically offer 2 plan options. A more expensive option, although still typically a lot less than any one of their plans today, where they can see any provider they choose. And then a much richer plan that is also much less out of the employee's paycheck. And that's a tough thing for people to get over. They're like, wait a second, why is the richer plan less expensive? Well, the richer plan is your direct primary care plan. And that means that this is your doctor. There's not a book that you get to choose from. This is your doctor. As a matter of fact, your doctor is right here at the open enrollment meeting because let me ask you a question, Brett. You said you have an 18-year-old, right?
Yes, sir.
When you taught he or she to drive, did you sit them down at the coffee table, open up the Geico booklet, go through all the provisions of the Geico policy, and then hand them the keys and say, go be a good driver? Of course not. As an experienced driver, you got in the car, and where do you put your hands, and how do you adjust the mirrors, right? But isn't that first scenario what employers do every year with employees? Don't they go through all the provisions of their Blue Cross and Blue Shield policy, what's covered under formulary, what's not, where the deductible applies, where it doesn't? And then they hand them an unlimited ID card, and they say, go be a good patient.
That analogy that you gave during another podcast interview is exactly why I got so excited to talk to you today, because that analogy right there is the biggest reason why this system is broken. And that's the virtue that you get when you get a primary care, not just a primary care doctor, but when you get a primary care benefits consultant like myself, it's literally the same thing that you're doing, right? We're designing health plans to create better outcomes, and you couldn't be any more correct than what you're saying. So let me ask you this. So when you guys are designing health plans, that's what I wanted to get into. So you've already got right into it. Do you basically bring the primary care doctor at your employer group's meetings to do that? Is that one of your requirements, or is that what you do most of the time, or how does that work?
Yeah, it's what we do most of the time because we want them to meet their doctor. Again, it's only if they choose the DPC plan. But it's important to me that, when I talk about, let me explain how your doctor's paid. Most doctors are paid with 2 metrics influencing their paycheck. The first is patient volume. Patient volume, the more patients they see in a day, the more money they make. Of course, the more patients they see in a day, the less time they spend per patient. But the other lesser known metric is called an RVU. And an RVU stands for relative value unit. And it's a measurement of how much money they're helping generate in other parts of the healthcare system. So if you come in even to your primary care doctor, which we've been encouraging you to go to first, but if you go to a primary care doctor that's working for a large health system, they have to see 30 or 40 patients a day. So they have to get you out the door quick. And they want to maximize the cost of where you go because that's how they get paid. So if you come into your primary care doctor with your back hurting, their most profitable path by far is to write you a script for an opioid to get you out of the office quick, and that's where most opioid addicts start, and to refer you to their buddy, the back surgeon, where the most likely outcome is back surgery, which is the most expensive fix to a back, if it's even a fix at all. So the entire system is predicated on costs going up, and I'm sick and tired of brokers and doctors largely claiming that they're not influenced by these incentives when they keep on perpetually delivering, at least in aggregate, what the incentives demand they deliver. And is there exceptions on both sides? Of course. There's some doctors that always do what's right for them and never what's right for the patient. There are some doctors that always do what's right for the patient and never what's right for themselves. But I think that most of them live in the middle. It depends on their day. But the point is they're paid in a way to feed their family that's contrary to what the patient and the employer combined want. And we need to start to address these incentives because unless we address them, we're never going to get out from underneath them.
Well, let me ask you a quick question, and we don't have to dig into this if you don't want to, but do you know Dale Folwell?
Mm-hmm. I know who he is, and I've spoken to him once or twice, but I don't have him on speed dial.
Okay, gotcha. Well, we just came back from the Free to Care Coalition conference here in Austin, and he basically shared some documents that he had requested from one of the big hospital chains that supports their healthcare. And basically, when he asked for all of the charges and the explanation of the benefits that they rendered, they sent him in the mail almost a ream of paper, literally. And on every page, there was a big black square, and it said that it's been redacted. They basically gave him the middle finger and said, we're the big hospital chain. We don't got to give you jack, and you're going to keep paying it. And David, the arrogance and what employers have to understand is that there is a healthcare cartel out there that does not have their best interest, the employers, and definitely not the employees' benefit at hand. And my job every day when I get out of bed is to fight that battle. And I think, I don't know how you feel, but I think that it's going to change, and it almost has to change. But what is your vision for the future with that?
Well, first of all, for those that don't know, Dale Folwell is the treasurer of North Carolina, and he actually put a plan in place that is very similar to the type of plans that we build for employers. Well, when it was announced that was going into effect, between that time and the time in which it was supposed to go into effect, all the carriers and all the health systems lobbied the politician, and it was killed by the North Carolina Congress. So he was trying to do what's right. He had lined it up, and then the hospitals and the insurance companies pushed back, and they got their way. So I give him a lot of credit, but he still didn't get it done. He did a couple things, but not the full thing that he wanted to do. My vision for the future is this. The future is now, Brett. Employers already have the biggest leverage in the world to fix it. They are the pocketbook. They just don't realize it. You know, a lot of people think that when you go fully insured, the carrier is taking all the risk. The carrier has no risk at all. Claiming that a carrier has risk is like claiming that my accountant has risk in my taxes. My accountant doesn't pay for anything. They just tell me who to pay and how much. And that's what United Healthcare and Blue Cross does for employers, whether you're fully insured or self-insured. You are not paying less money being fully insured. I mean, just look at the share prices of the carriers. When they come in with their, excuse my French, BS line, every renewal where they say, oh, your claims were above premium, aren't we great for you? And you're only getting an 18% increase, but really you should get 40%. All of that is BS. And I know deep down inside, most employers know that. They just don't know why or how.
They don't know how to fight it.
That's what we show them.
They don't know how to fight it. They think
but it already is fightable.
Exactly. And they think that they need a quote unquote fancy, glossy insurance card that's just really making a whole bunch of people rich and all their employees poor. And then we're wondering why we have recruiting and retention issues with employers across the country. And we're talking about it right now. So we could talk about that. And I know we're both passionate about that. So I appreciate you kind of leading the way and leading the charge over these last few decades here. But let's walk into some stories now, because you obviously understand and have mastered this craft. So talk about some stories. You were just talking about an airline out of Alaska and what their results were, but I want you to give a few stories and kind of paint the picture, give some context with these stories.
Yeah. Well, I want to tell you the story that touches me the most. We have a client up in Wisconsin. They have some Subway restaurants, you know, the sandwich restaurants, and some auto parts stores. So their employees are not high paid. And one day we put our plan in place. A couple of weeks later, one of the managers, so higher paid, but still very low paid, she comes into the owner. It's a family run business. And she goes into the owner and says, hey, Tim, there's a problem with our new health plan. And he said, what's wrong? And she said, well, you know, I have this chronic disease and I have to pick up this very expensive medication. And every year when the plan renews, I have to pay thousands of dollars out of pocket before the plan starts to pick some of it or all of it up. I went to pick the drug up today for the first time under the plan. I didn't pay anything for it. And Tim said, no, that's correct. You did what you were supposed to do. So we covered the full cost. And she said, please don't mess with me, Tim. And he said, I'm not. And she started to cry. See, this was a working family, couple of kids, husband, wife, both working, both trying to make ends meet. And they had to pay $6,000 a year out of their pocket just for that drug, just her share of that drug. She tells Tim that if what he's telling is true, she's going to be able to take her family on vacation for the first time since she was diagnosed with this disease 10 years ago. Now, at the same time, that drug had been costing the plan $10,000 a month. I was able to get that drug for free from the manufacturer, for free to the plan and for free to the member. So it saved the plan a ton of money, and this member can now take her family on vacation again. That's the type of savings we're talking about. So let's talk about some of the savings, because it comes from a multitude of different areas within our plans. But on average, and I know this sometimes sounds too good to be true, but on average, we save somewhere between 30 and 60% in the first year over what they were spending the year before. We typically get another lower double-digit decrease in the second year. Somewhere around the third or fourth year, we've sort of wringed out all the excess, got everything humming, working well. And now our goal is to keep that much lower number under a certain inflationary rate, usually 2 or 3%. So I'll give you a couple stories around that. One client, this had been a client of mine for 20 plus years. It was the first, what I thought was a big client back in the day. And they were with me for 15 years with Cigna largely. And so I had 15 years of history of rate increase. In 2017, 5 years ago, they decided to go into this new model that I had been putting together. Today, back then they had 363 employees. Today, they are spending 10% more. They were spending $4 million. Today, they're spending $4.4 million on 900 employees.
Repeat that again.
They are spending 10% more than they were spending on 363 for almost triple the number of employees.
Unbelievable. Great job, David. That is phenomenal.
This one client, let me tell you some of the common sense things we did. This company has a lot of tree climbers. They had a lot of orthopedic issues. There was a lot of orthopedic surgeries going in. So you know what we did? We put in 20 visits of no-cost physical therapy. The orthopedic surgeries plummeted. We saved so much money at the end of the second year. We did a survey to all the employees, and we said, what do you want to see in your health plan? The number one thing they wanted to see was a massage benefit. So now every member of the plan gets a no-cost massage every month, paid for by the health plan for a small pittance of the cost. For this employer, over the course of the first 5 years that are already done, we saved them almost $40 million. The projection of things are going over the next 5 years will save them a cumulative $75 million. These are big numbers we're talking about here. And all the while, employees are getting care and medication often at nothing out of pocket. And they still have some of the richest plans. One of their plans is a $500 deductible with $1,000 out of pocket. And they've been going down 20% a year every year for the last 5 years.
Unbelievable. I love it.
So you asked about the airline. So we have a client that's an airline, small airline. And through July of last year, with their Blue Cross and Blue Shield plan, they had spent $1.8 million. Through July of this year, they spent $565,000 on the same population of employees.
Unbelievable.
So here's what I want employers to think about for a second. There's two things that I hope will compel you to do something different. First, not selfishly, your employees are most likely suffering under the out-of-pocket that's required into their plan. They're either afraid to use it, and therefore their clinical state is getting worse, which is only increasing the likelihood of large claims, or they're having to choose between their diabetes medication and putting food on the table. Either way, a huge majority of employees in most organizations are facing that every single day, and that's combined with what's coming out of their paycheck. So from a non-selfish perspective, for any employers listening, I encourage you to do this for your employees. But I'll give you a selfish reason too. Right now, attracting and retaining talent is pretty difficult for most businesses. So let's say you have an employer that's paying 75% of the cost of healthcare. The employees have 25% coming out of their paycheck with a high deductible. If I could save you 40%, which you would be one of our lower performing clients if that were the case, you could afford to pay 100% of the cost and still be paying less than you're paying today. And as I've mentioned multiple times, our health plans give access to care and medications at nothing out of the pocket. So here's my question. How much easier would your HR department have in attracting and retaining employees if you were out there saying we have nothing coming out of employees' paychecks, even for family, and you can often get care with nothing out of your pocket? That's the selfish reason.
Well, David, here's what I want to say to employers out there. I don't need to do another podcast episode ever. All I need to do is just repurpose this podcast every single week, and employers will get the solution that they've been looking and praying and hoping for right in front of them. And it requires a broker or a consultant like David, like a direct primary care outfit that is going to fight on your behalf to help you navigate the healthcare system. Health insurance companies are simply put together to tell you where to go, like you mentioned, but you want your doctor that you trust to tell you where to go. And the only way that they're going to have the ability to do that effectively is if they have the time to understand what your stress is like, what your daily activities are like, what you're eating, how you're exercising, and all of the things that direct primary care doctors do. And so I am just so stoked about this interview. So appreciate everything that you've mentioned here. David, please share with all of our listeners. Obviously, we've got people that listen all across the country. Tell them how they can get a hold of you. Tell them the best place to go, because you obviously are out there every day helping fix healthcare, and I want people to make sure that they have access to you. And I'd love to be your preferred vendor in Houston and Texas for any plans you put together out here.
Great. I'd be happy to talk to you about that. Well, I'd like to, before I give my contact information, I want to give my stroke of genius for the day. There's only one way for an employer to pay less for healthcare. They have to pay less for healthcare. And if you're not working with someone who can directly demonstrate how to take something that occurred yesterday and make it cost less tomorrow, whether it's a surgery or a drug, and I'm talking not in general, not discounts. Discounts don't mean anything. Discounts don't mean anything when the starting price is not the same. If your carrier is coming in saying, we're going to give you a better discount than your other carrier, ask them, well, what's the starting price? Is it the same as them? And they won't be able to tell you. You have to pay less for healthcare because, let's face it, the amount of money going into a plan, premiums, deductibles, copays, is a direct result of the vacuum left by the money coming out of the plan. You can't solve this problem by switching carriers or raising deductibles. Here's a question, another analogy. You go to buy a car. Your budget for your car payment is $300 a month, but the car salesperson is so good you wind up with a $1,000 a month car payment to the bank. And so a couple months later, you sit down with your significant other because that payment is just killing your finances, and you say, we need a strategy to lower our bank payment. Is switching from Allstate to Geico, even if you save 15% on your car insurance, is Bank of America going to say, okay, now your car costs less? What if you raise your deductible on your car insurance from $500 to $1,000? Does Bank of America care? Or what if you self-fund your car insurance? You put money in the bank and just pay for it if it happens. Does Bank of America lower your car payment? Mm-mm. The only way to lower your car payment is to have a less expensive car. The cost of insurance is irrelevant. It's minuscule compared to the cost of care. But the premium that you're paying if you're fully insured is a combination of premium and cost of care put together. We focus on care, and here's the beautiful thing about our healthcare system. Here's a little bit of hope to hang your hat on at the end of this podcast. Cost and quality in the U.S. healthcare system are inversely related. In other words, we have access to cost and quality at almost every doctor and every hospital across the country. And if you sort them by highest quality on the left to lowest quality on the right, you're also sorting them by lowest cost on the left to highest cost on the right. So why are we not using real data to encourage, incentivize, or drive people to where the outcomes are better and the costs are lower? Doesn't everyone benefit from that except the carriers and the large health systems? The people that we really care about benefit from that. So having said all that, a couple of ways to get in touch with me. First off, we have an annual symposium we put on every year. It'll be our second one in February in Miami in February of 23. Our first one was in February of 22. We had hundreds and hundreds of brokers, consultants, employers, doctors, vendors that we use in our plans there. It's a great education for anyone who's interested. We're going to have an entire DPC track this year that we're developing with a few other direct primary care physicians to have content specific for DPCs or doctors considering doing DPC. My wife/business partner and I also teach a course that teaches brokers and consultants how to do this. We also partner with brokers and consultants to help them do this for their clients, for a couple of them, until they get it and can do it on their own. And of course, we work with employers directly. The best way to get in touch with me is probably LinkedIn. Luckily, my name is relatively uncommon, so just David Contorno on LinkedIn. Connect with me. I put a lot of content out there. And what's really fun is because I'm no longer paid by the carriers, I can poke the bear. Back when I was still being paid by the carriers, they would come to me. The executives would fly in and say, David, if you keep pushing this alternative agenda, we're going to cut your contract. And when United said that to me, and 45 or 50% of my agency revenue was coming from United Healthcare, if they cut my contract, I would have been out of business. I would have had to fire 3/4 of my staff. It would have been life-changing for me and a dozen of my employees at the time. But that's what they wield. So I wound up selling my agency a few years ago, and I committed to never taking money from the carriers again, because it puts you in a position you can never get back out of. So today we only get paid by our clients because that's who you work for. I believe that you work for whoever pays you. And if Blue Cross and Blue Shield is paying your broker, then that's who your broker works for, period.
Amen.
Change
Amen.
the system. We can do it.
Hey, well, David, listen, I am so excited for our relationship, and I am praying and believing that it'll continue, and I am looking forward. I don't know how, but I'm going to be at your symposium in February, so I'm going to get some details with that. Great. And I definitely want to have a conversation offline about DPC and how we can help with that particular venue portion of your event. So thank you so much for your time, and I just appreciate you so much for taking this time out. So again, I can't say how much I appreciate you for taking the time today.
Thanks for having me.
Well, ladies and gentlemen, that is going to conclude episode number 8 of Direct Primary Care Benefits Podcast with David Contorno of ePowered Benefits. So excited for everybody to listen to this. And I want to encourage you, if you got value from today's episode, please go and rate, subscribe, follow us, check out our YouTube channel on Direct Primary Care Benefits Podcast. We've got tons of content and episodes just like this. And I want to just thank each and every one of you for listening. Thank you for sharing, because we are on a mission, and that mission is to fix healthcare. So thanks so much for listening. This is Brett Shoemaker, your host. Have a great day, and God bless.